The subcommittee will come to order. Chair recognizes himself for 5 minutes for an opening statement. The topic of today's hearing is the purchase of health insurance across state lines. Cross-state line purchasing of health insurance allows health plans to be portable, to move with an individual from job to job and state to state, and gives Americans a wider range of plans from which to choose the one that suits them and their families best. Every state has health insurance mandates, from Idaho with the fewest, 13 mandates, to Rhode Island, topping the list with 69 separate mandates. My home state of Pennsylvania has 57. Altogether, the Council for Affordable Health Insurance has identified a total of 2,156 mandates across the 50 states and the District of Columbia in 2010. These range from benefit mandates to provider mandates to groups of people who must be covered. Each mandate makes the policy sold in that state more comprehensive. However, each mandate also increases the cost of those policies. Most mandates increase the cost of policies by less than 1%, which doesn't sound like much, but when a state has 30, 40, or 50 mandates, and some mandates can add 5% or even 10% more to a policy, you're quickly pricing many people out of the market completely. By some estimates, an average of 30 to 40 mandates can increase the total cost of a policy between 20 and 45%. States have begun to realize that while well-intentioned, mandating important health benefits and provider coverage for their citizens has backfired. At least 12 states now allow mandate-free or mandate-light policies so that people can buy a plan that is more suited to their needs with fewer costly mandates. Additionally, nearly 30 states now require a cost estimate of a potential mandate before it can be enacted. This should be about consumer choice, not a one-size-fits-all state mandate package that may or may not address a particular individual's needs. This is about empowering people to make decisions for themselves, not assuming they need the government to protect them for themselves. If a Pennsylvania policy contained mandated benefits that I determined I did not need or want, why shouldn't I be able to buy a policy from New Jersey or New Mexico? Why shouldn't I be able to shop among different states and buy the policy that is at the best price for me and is the best tailored to my health needs and my situation? Furthermore, why shouldn't I expect that when states and plans have to compete for my business and not take it for granted that costs will go down and quality will go up? So with those introductory remarks, I want to thank our witnesses, and I'd like to yield the remaining time to the gentlelady from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman, and I thank you and Chairman Upton for holding the hearing today to discuss what I think is an innovative approach, and of course I believe this is important legislation for us to take up. Thank you to our witnesses for your preparation and your presence here today. You know, nearly 51 million Americans are lacking health insurance. 85% of the uninsured workers cite unaffordability is the top reason for why they are uninsured. And this is something there's something we can do about this. The Health Care Choice Act, which is only 31 pages long, will harness market forces to lower the cost of health insurance and reduce the number of uninsured Americans by 12 million without any cost at all to the federal government. It's the right type step. In 1965, there were only 7 state benefit mandates. Today, there are over 2,100 mandates on health insurance coverage. These mandates have increased health insurance premiums between 10 and 50% for American families. For example, in a high mandate state like New York and Massachusetts, the average family premium is just over $13,000. Right across the river, in a lower mandate state like Pennsylvania, the average is just about $6,000, which is about the same price as in my home state of Tennessee. This bill would give consumers the option of buying health insurance that meets their needs and is right for them and their family, even if that means buying a policy that is qualified in another state. And while I may prefer a plan that includes a chiropractor, that choice isn't going to be right for everyone. So let's give consumers the choice. As Speaker Hastert used to say, we shouldn't be forcing people to buy a Cadillac when all they need is a Chevy. This bill will lower health insurance costs across the country by cutting red tape. Insurance plans won't have to go through 50 different state certification process. The result will be significant savings in the cost. And it is important to note that this bill will not decrease consumer protection or act as a race to the bottom. As I told President Obama when we did the health care forum at the Blair House, this bill will let the people out of their states and allow them to choose a product that is good for them. Thank you, Mr. Chairman, and I yield the balance of my time.
Chair, thanks, gentlelady, and now recognize the ranking member of the subcommittee, Mr. Pallone, for 5 minutes for opening statement.
Thank you, Mr. Chairman. Allowing Americans to purchase insurance coverage across state lines is not a new idea. In fact, it's an idea that has been promoted by Republicans for many years and one that was extensively debated in this committee in 2005. And I think many who sit here today remember those proceedings, so you all know very well that I'm strongly opposed to such proposals. But what I'm even more opposed to is the way Republicans purport this idea as a proposal that would give consumers choices and access to more affordable health insurance. Because the truth is, it does nothing of the sort. The only choices offered by this proposal are for insurance companies. They're the only ones that gain. It gives the insurance industry the choice to do business in the states that have the most favorable business climate and the weakest consumer protections. The result is a complete circumvention and preemption of state laws, and it would end state regulation as we know it. Now, state regulation and patient protections are vital to protect those who reside in that state from unscrupulous actors. Regulation is needed to protect those who would otherwise have no protection. If H.R. 371, a bill introduced by Representative Blackburn entitled the Health Care Choice Act, or any other bill that attempts to allow an insurance company to license their product in one state and sell insurance in another state, if any of those bills were to become law, it would quickly result in a race to the bottom among health insurance plans, a race that would drag down patients in its wake. H.R. 371 allows insurance companies to choose to operate under the laws of states with weaker consumer protection and risk pooling standards. By doing so, plans will be allowed to cherry pick the best risk, leaving older, sicker individuals isolated in pools without healthier individuals to offset their medical costs. And the result will be insurance markets in disarray without any real pooling of risk. Furthermore, state regulators would be unable to provide assistance to individuals in their own states who opt to purchase coverage from a carrier selling under a second state's law. In my home state of New Jersey, we've enacted extensive reforms that go beyond what many other states offer. And thanks to these consumer protections, New Jersey is able to ensure that its residents have access to quality individual insurance products. But in order for New Jersey to guarantee access to this kind of insurance, it must be able to spread risks throughout the market. And that means pooling low and high risks together. If H.R. 371 were enacted, it would completely dismantle New Jersey's existing risk pool. Younger and healthier consumers would flee New Jersey's market in order to obtain cheaper policies that provide less coverage, leaving only high-risk consumers in the market. Now, I don't think we can move back to a system with zero patient protections, putting insurance companies back in charge. This is the very thing that Democrats were trying to reverse when we passed the Affordable Care Act. We don't want to empower insurance companies. So I can't conclude without pointing out that H.R. 371 also reveals the very popular and critical Patient Bill of Rights provisions of the Affordable Care Act. That's no surprise. The insurance companies didn't like those things either because they want to discriminate. So the protections that would be repealed include, among others, prohibiting gender rating, prohibiting the denial of people and children with pre-existing conditions insurance, outlawing rescissions, and prohibiting annual and lifetime limits on insurance. These are the anti-discriminatory practices that are already in effect under the health care reform, in which my constituents say they very much like. These are all gone all for the purpose of helping out the insurance companies because the Republicans simply want to be with the big insurance companies. The Affordable Care Act also created state-based health insurance exchanges which would allow other insurance carriers to come into states, thereby increasing competition and lowering premiums. But the stark difference, of course, from the Republicans is that the insurance companies would have to comply with federal and state mandates for coverage under the Affordable Care Act. And I'll also point out that the Affordable Care Act includes a provision known as health care choice compacts that allows insurers to sell insurance across state lines and only be subject to laws in the issuing state, but it includes protections for states and consumers. And again, the difference, Affordable Care Act puts the decision to allow the insurer to sell across the line in the hands of the state where the product would be sold, not in the hands of insurance companies. My whole point here is, look, I understand you're talking about selling insurance across state lines. That can be done, but it can't be done in a way that simply gets rid of the state protections, eliminates the risk pools, and puts all of the choices in the hands of the insurance companies. That's what you're doing with Ms. Blackburn's bills, her bill, and others that might be like it. And that's exactly what we don't need. It's not a problem to be able to sell across state lines. It's the patient protections that need to be in place. Again, I guess this is one case, Mr. Chairman, where the Republicans actually do have a replace plan, but I think that this replace plan is not one that's good for the American consumer, and I think it just puts the country's health system in a lot of trouble. So thank you for giving me a replace plan, but it's not one that I think that we should enact into law. I yield back.
Chair, thanks, gentlemen, and now recognizes the full committee chairman, Mr. Upton, for 5 minutes.
Well, thank you, Chairman Pitts, for holding this hearing. 2 weeks ago, the committee reported out legislation that will help lower health care costs by enacting real medical liability reform. Today, we're going to continue to examine ways that we can replace last year's health care law with common sense solutions that actually do lower costs. You heard our side talk a lot about repeal and replace, and I believe that this is one of those replacement planks, and commend my colleague, Mrs. Blackburn, for leading the charge on this issue. Allowing Americans to purchase coverage across state lines is an idea that has been gaining momentum for good reason. Individuals do use and shop for products every day that are made in other states. Yet in healthcare, individuals are prohibited from purchasing coverage across state lines. This policy has major implications for families across the country looking for affordable health care plans. States have imposed over 2,100 benefit mandates on health coverage. Estimates show that these requirements increase premiums anywhere from 10 to 50%. Consumers are forced to buy a Cadillac health care plan. They aren't even given the option of something that might better fit their need. And as a result, many individuals choose to go without any health care coverage because of the costly mandates. States are realizing benefit mandates are a problem that have to be dealt with. 15 states are now considering legislation to allow individuals to purchase coverage across state lines. 2 states with very different political backgrounds, Georgia and Maine, have already recently enacted laws to promote interstate purchase. Even our Democratic colleagues demonstrated that they understood the problem at some level. Section 1311D3 of PPACA requires states to assume the cost of mandates and make payments to individuals or health care plans to defray the costs of added premiums. I may disagree that this is the best solution, but at least they admitted that we have a problem. This hearing is about promoting flexibility and reducing costs. It is a stark contrast with PPACA, which doubles down on Washington control of health care. HHS will design the health plan that every American must buy under the threat of a fine from the IRS. Empowering consumers is the key to controlling costs. American families know the value of their dollar. If given the chance, they'll demand health plans that provide better quality at lower costs, something the federal government has consistently failed to do. The question is, will Congress and the President give the people the freedom? I look forward to hearing testimony from today's witness and would yield to my friend, the Chairman Emeritus of the full committee, Mr. Bart.
Thank you, Mr. Chairman Upton, and I'll be very brief. In a prior Congress, we passed a bill very similar to this bill out of committee. It was a priority of then Speaker Denny Hastert and our former member, John Shadegg. There are over 2,000 state mandates in the various states, and the premiums vary from about $5,000 to about $13,000. So it's obvious if you allow plans that are covered in one state, that are approved in one state, to be offered across the state line, it's going to promote competition and it should lower cost. So I'm very happy that Chairman Upton and Subcommittee Chairman Pitts are holding this hearing, and I would yield the balance of Chairman Upton's time to Mr. Shimkus.
Thank you, Mr. Chairman. I would just want to add that insurance products aren't bad. In the era of multiple natural disasters, we'll see that many people will get recovery because of an insurance product. They'll get recovery for their automobile. They'll get recovery of their home. And, you know, this attack on a sector that really helps people recover from disasters is always a little frustrating. And that all we're trying to say in this debate is those type of policies can be used in the healthcare industry. It's just some state mandates get in the way of really having a competitive product. I'll give you one example. State Senator in my state of Illinois said the largest increase in a health insurance policy was when the state mandated contraceptive coverage. Now, should you be forced to buy an individual package that has contraceptive coverage and raise your rates? Many of us would argue, no, you should not. Should there be minimum coverage for things that an insurance commissioner would want to get involved and engaged in and help resolve disputes? Yeah. So I think there's a middle ground here that we could reach, and I'll end on saying I do think this is one of many steps that we will have to address the replace aspects of Obamacare as we move forward. And I yield back my time.
Chair, thanks, gentlemen. Recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Mr. Chairman, up until today, this committee only acted to repeal provisions of the Affordable Care Act. Today, for the first time, we see what the replacement is. However, this replacement clearly fails to keep the promises made in the Republican resolution to replace the Affordable Care Act, and it would be a step backward for the American people. The Republicans promised to increase the number of insured Americans and to lower health care premiums. For people who are sick, where insurance is a lifeline, this proposal of allowing insurance companies to sell their product across state lines does just the opposite. The Congressional Budget Office analyzed the legislation introduced by Representative Blackburn in 2005 when it was supported by Mr. Shattuck. In its letter, CBO said there would be very little effect on the rate of uninsurance, that this proposal would cause families to lose employer-sponsored insurance and those needing health care to lose insurance in the individual market. That's a far cry from the Republican claims that this bill will cover millions of the uninsured. CBO also noted that the bill would increase the price of coverage for those expected to have relatively high health care costs. Now, how is increasing premiums for the sick, who already spend dollars on health care at the expense of rent and food, a step forward in providing quality health care? This bill basically asks someone with diabetes or breast cancer to pay more or go without health insurance so that someone else can pay less. In other words, they're supposed to buy a lower priced car. Well, I don't think they're going to be able to buy anything because they still can be excluded for pre-existing conditions. The goal of the Affordable Care Act is to make affordable coverage available to everyone, sick and healthy alike, not to help one group of people at the expense of another. Let's be clear. States have long had the ability to allow sales of insurance across state lines, but they could control how it happens and when it happens, and the Affordable Care Act affirmed that policy. Today, Maine, Georgia, and Wyoming have passed laws to allow purchasing across state lines. Maine and Wyoming decided to allow this with a limited number of states, but the federal preemption of their laws by the Blackburn bill would require they open their borders up to every state in the country. Numerous other states are debating pending bills, and any legislation is merely preempting the state's prerogative to do it their way. That's an amazing thing from the Republicans, who say that states ought to be able to act on their own. All wisdom's not here in Washington. Instead, here in Washington, we would tell the states, you can't do it your way, you've got to do it our way. Well, Governor Jan Brewer of Arizona last month vetoed a bill that allows selling insurance across state lines, saying that this, quote, provision would change Arizona's benefit requirements based on legislative decisions in other states. She also said she's concerned about other risks to our citizens who may be subject to other states' regulatory procedures that could leave them with little recourse in the event of mistreatment. The proposal before us today would not allow states to permit the selling of insurance across state lines. It would require it to be done the way the federal government insists. This bill is unlike the Affordable Care Act, which regulates insurance to set a federal minimum standard, but permits states to go further to protect their state's residents. Republicans claim to support the authority of states to govern themselves as they see fit, but this is not what they stand for when it comes to legislation. The people with breast cancer, diabetes, and newborns have been guaranteed coverage for their services by most, but not all states. So when the federal government comes in and preempts those state laws, patients with breast cancer and diabetes may not be able to find insurance that covers their treatments and testing. You know, if it's covered in another state, doesn't mean the insurance company that's offering a bare bones package in another state is going to offer it in every state. We don't mandate the insurance companies to do anything. We only mandate that states allow those insurance companies who think they can make a buck come in and sell it, if they're allowed to sell it anywhere else. Critics claim that state benefit requirements add as much as 50% to health insurance premiums. According, if I might, Mr. Chairman, according to a more impartial source, the National Association of Insurance Commissioners, it was less than 5%. This proposal is a bad idea on its own terms. As a replacement for the Affordable Care Act, it's disastrous. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. I'd like, again, to thank the witnesses for agreeing to appear before the committee this morning. Your willingness to take time out of your busy schedules underscores just how important this issue is to all of you, as it is to all of us. Our first witness, Mr. Steve Larsen, is the director of the Center for Consumer Information Insurance Oversight at the Center for Medicare and Medicaid Services. Our next witness is Dr. Stephen Parente, is the Minnesota Insurance Industry Professor of Health Finance and Insurance in the Department of Finance in the Carlson School of Management at the University of Minnesota. Christy Herrera is the Director of the American Legislative Exchange Council's Health and Human Services Task Force. Stephen Finnan is the Senior Director of Policy for the American Cancer Society's Cancer Action Network. And lastly, Dr. Paul Howard is a Senior Fellow at the Manhattan Institute. Your written testimony will be entered into the record. We'd ask you to summarize in 5 minutes. Each of you, Mr. Larsen, you may begin your statement.
Good morning, Chairman Pitts, Ranking Member PALLONE, members of the subcommittee.
Is the mic on?
Can you hear it?
Yeah.
Yeah? Okay. Thanks for the opportunity to appear here today. I've submitted my full testimony for the record. I'm pleased to be here and have the opportunity to comment on the issues related to the sale of insurance across state lines. I know we all share the same goal of assuring affordable and comprehensive insurance options for individuals and families, and I believe we also agree that healthy competition among private insurers can help drive costs down and provide more consumer choice. But in our view, the Affordable Care Act accomplishes these goals in the best possible way. First, in 2014, state exchanges will foster competition among insurers by having insurers compete on the basis of price and quality rather than on their ability to underwrite those who need insurance the most, people with pre-existing health conditions. The Affordable Care Act also creates transparency, a key component of a healthy, competitive market. State health insurance exchanges provide transparency to consumers who can make apples-to-apples comparisons of coverage options and allow people to understand in plain English what they're buying and how it will protect their families. The Affordable Care Act ensures consumers get the benefit of a core set of consumer protections, protections that are critical to a well-functioning market. In 2014, insurers will be barred from denying coverage on the basis of health status, and consumers will have high-quality coverage. The Affordable Care Act also provides key protections and benefits that have already taken effect, such as the prohibition on rescissions and bans on lifetime limits on insurance coverage. We also expanded access to care for young people by providing coverage for dependents up to age 26 on their parents' policies, a benefit to over 600,000 young adults already. In addition to the provisions of the Affordable Care Act, many states also have basic consumer protections, including reasonable rating bans or corridors and restrictions on underwriting. These ensure that people with medical conditions are not excluded from insurance coverage. Many states also have laws to ensure consumers have access to an adequate network of specialists and other healthcare providers, and many have mechanisms to deal with complaints consumers might have in dealing with their insurance company. The Affordable Care Act allows consumers to continue utilizing the staff of these state insurance commissioners when they have issues, concerns, or questions. Speaking from my firsthand experience as a state insurance commissioner for 6 years and also director of SCIO, the proposition of allowing interstate sales of insurance in a way that eliminates or overrides a state's own authority to protect or assist insurance consumers in their market is, while well-intentioned, a step backward in the effort to provide accessible, affordable, and fair health insurance coverage to all citizens. Allowing insurers to pick the state they want to be regulated in provides the insurers the choice of which state laws they have to comply with. Insurers can then issue policies with fewer benefits or protections in other states that otherwise would not allow such policies. The laws of the issuing state become a ceiling or a cap for other states. This will likely lead to cherry picking of healthy groups and individuals. And we know from experience that when we segregate risk pools by selectively selling policies with thinner coverage or fewer benefits, we drive premiums up for the rest of the population. State insurance regulators, legislators, and governors would be powerless to try to fix this because they would have no jurisdiction over these policies. In addition, proposals that preempt state insurance laws in one state with those of another leave consumers at a disadvantage. State insurance regulators often provide key consumer assistance to residents of their states. If state regulators were no longer able to provide these services to purchases of interstate policies, consumers in one part of the country would be dependent on the time and resources of a state regulator thousands of miles away. It is likely many consumer complaints or problems would go unaddressed. Insurers can already sell insurance across state lines so long as they comply with state laws. Many companies today operate and provide insurance in multiple states. In summary, the Affordable Care Act has increased consumer protections and will lead to more affordable, comprehensive insurance options. Interstate sales, where the laws of one state preempt those of another, would leave many consumers with less affordable coverage and no one to turn to if they needed help navigating the market. Thank you.
Chair, thanks, gentlemen. Dr. Parente, you're recognized for 5 minutes for your statement.
Thank you, Congressman Pitts and members of the committee for this opportunity to speak to you today. My name is Steve Parente. I hold the Minnesota Insurance Industry Chair in Health Finance at the University of Minnesota, and there I serve as a professor in the finance department as well as running a medical industry MBA program. My areas of expertise are health economics, health insurance, and medical technology evaluation. Most recently, I and my colleagues Roger Feldman, Gene Abraham, and Wendy Zhu at Minnesota completed a study on the impact of allowing consumers to purchase health insurance across state lines. This peer-reviewed study was accepted for publication last winter as forthcoming in the Journal of Risk and Insurance. And on a side note, I must say that the deliberations of this committee 5 years ago were the inspiration for that publication. I have provided a copy of that publication with my remarks for your consideration. In this study, we find evidence of a significant opportunity to reduce the number of uninsured under a proposal to allow the purchase of individual health insurance across state lines using 3 different policy scenarios. First, the best scenario to reduce the uninsured numerically is competition among all 50 states where one or more states emerge as dominant players. This scenario would yield a reduction in the uninsured by 8.1 million people. And with all due respect to Congressman Waxman, insurers don't like this because it puts them at civil war with each other. That's one reason why this hasn't moved forward. This idea is not without precedent outside healthcare delivery, where Delaware has become the most favored state for incorporating a firm. Second, the most pragmatic scenario with a good impact is one state dominating each regional market. In this case, the uninsured will be reduced by 7.4 million. This is a compromise since the U.S. health insurance industry is only halfway national through national employers contracting with insurers through ERISA. This could be provide a practical, more politically palatable approach to giving coverage. Third, the 5 largest state scenario is the least effective policy for increasing the number of insured people. This is likely due to the fact that only one state of the 5, Texas, has a combined regulatory burden that is less than the 50th percentile of all states. The estimated reduction from the 5 large state scenarios is 4.4 million individuals. It is important to note that these reductions in the uninsured could be achieved without the premium subsidies or Medicaid expansion policies prescribed in ACA. In the paper, we did model the impact of combining interstate purchase of insurance with subsidies for private insurance and found additional reductions in the uninsured were possible, in many cases doubling the reductions. Albeit this could happen at considerable cost, though. The changes we found also took into consideration the different market prices between communities for medical care. For example, the cost of living for nurses in Manhattan are higher than those living in Missouri. These differences were factored out. As a result, the impact is almost entirely due to differences in the regulatory burden and mandates between the states. In one of the most telling illustrations, we found premium quotes for the same family from the same insurance company for the same insurance benefit to be twice as expensive in a New Jersey town, Lambertville, compared to New Hope, Pennsylvania. These 2 towns are separated by a 1/4 mile of Delaware River, but their citizens are likely to use many of the same doctors and hospitals. It is understood that policy simulations simplify many political barriers, but the opportunity cost of not allowing interstate sales might motivate the development of legislative and contractual agreements to divide regulatory powers between primary and secondary states. This could be consistent with the exchange policy as well. Of course, adequate disclosure to consumers of the primary and secondary states' obligations will be paramount for this to work. One possible outcome is that consumers who buy insurance in one state but live in another could have 2 insurance regulators looking out for them rather than just one. This would address a substantial concern that demandating the market could leave consumers without adequate consumer protection. At the same time, if the effect of mandates on premiums substantially reduces the probability that someone would buy insurance, one must ask, which is the worst outcome? Lack of coverage for a given service or no coverage at all due to higher premiums from mandates? Although we have modeled the person-level impact of a national market on coverage, we are unable to assess the impact of such a migration on provider access as well as quality. Nevertheless, a national market could lead to substantially more health insurance, even those with chronic conditions and pre-existing conditions. In addition, development of a national market requires no additional federal resources other than the support for this legislation to permit the development of such a change. In closing, I hope these new findings will be considered by the Congressional Budget Office if and when this topic is considered formally. CBO frequently uses peer-reviewed studies as a basis for policy impact. I hope this new study will be considered and that any opportunity with such potential to reduce the uninsured gets serious consideration amidst the fiscal constraints that can handicap so many of the other coming health reforms to be implemented under the Affordable Care Act in 2014. Thank you.
Chair, thanks, gentlemen. Recognize Ms. Herrera for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Mr. Chairman, Ranking Member Pallone, can you hear me?
Can you hear me now? Perfect. It's a pleasure to be before the subcommittee today. I am Christy Herrera. I'm Director of the Health and Human Services Task Force at the American Legislative Exchange Council, or ALEC. ALEC is a nationwide nonpartisan organization of state lawmakers. We have nearly 2,000 legislator members across the country, about a third of all legislators nationwide. Today I'll briefly address how an interstate market could bring about affordability, innovation, and choice. And I'll also discuss some nascent state proposals that have already been mentioned here: Wyoming, Georgia, Maine, Arizona, and Oklahoma. Simply put, our nation faces a crisis of the uninsured. 1 in 6 Americans lacks health coverage, and increasing numbers either can't afford it or choose not to purchase it at all. Many states are considering legislation to allow the purchase of health insurance across state lines. ALEC believes that these are promising proposals that could bring about affordability, innovation, and choice. First, affordability. Many Americans live in states where high-cost health insurance is the only option, and where more affordable plans can be found just across the state line. Innovation. When we open up these coverage options, individuals could benefit from innovative plans in other states, and state lawmakers could benefit from new ideas in other states while maintaining core consumer protections in their own state. Choice. People could choose more customized health plans that meet their health needs. As has been mentioned, each state imposes mandates that require individuals to purchase coverage for specific benefits, procedures, or providers in order to purchase health insurance coverage at all. While these mandates may make coverage more comprehensive, they also make it more expensive, and it can price people out of the market altogether. An interstate market could allow people to purchase out-of-state coverage with fewer mandates, or allow people to top up for richer coverage in another state. ALEC is generally supportive of any proposal to allow the purchase of health insurance across state lines. However, ALEC believes that it is the states that are best equipped to develop and implement this kind of targeted health reform solution. First, the states are both constitutionally and statutorily authorized to have primary regulatory authority over health insurance, but more importantly, we believe that states can develop their own policies that reflect their own unique circumstances, and this kind of pluralistic state approach can yield best practices with implementation. We began tracking state-level legislative activity in 2007 when our legislators adopted Model Healthcare Choice Act for states. This is state-based model legislation that vests authority in the state's insurance commissioner to allow the sale of health insurance across state lines. In 2011, 15 states considered this legislation. Last year, Wyoming became the first state to enact this kind of legislation. Wyoming's law would establish a multi-state consortium that will establish reciprocity agreements for the approval, sale, offer, and structure of health insurance plans. This month, Georgia and Maine became the second and third states to allow cross-border purchasing of health insurance. In both states, individuals who apply for an out-of-state policy will receive a disclaimer noting which state's laws govern benefits and underwriting. Georgia's law gives wide latitude to a state's insurance commissioner to qualify the sale of out-of-state plans, and it also allows Georgia's own insurers to sell products that are similar to those out-of-state plans. Maine's law establishes what are called regional insurers, headquartered in Connecticut, Massachusetts, New Hampshire, or Rhode Island, and it allows these regional insurers to sell health insurance policies in Maine. These out-of-state plans must comply with the individual health insurance laws of its home state and also comply with Maine's consumer protections. Also of note are the Arizona and Oklahoma approaches that would respectively open Arizona to a 50-state market for health insurance and allow Oklahoma's governor to negotiate interstate compacts in this area. In conclusion, ALEC believes in the promise of these state-based initiatives because they can help many Americans choose affordable, innovative, and customized health insurance coverage across state lines. These state-level reforms have only just begun, and now is the time for the states to develop these proposals, to glean best practices for implementation, and hopefully to demonstrate success. Thank you.
Chair thanks gentlelady and recognizes gentleman Mr. Finnan for 5 minutes for an opening statement.
Good morning, Mr. Chairman, Ranking Member Pallone, and distinguished members of the committee. I am Stephen Finan, Senior Director of Policy at the American Cancer Society Cancer Action Network, which is the advocacy affiliate of the American Cancer Society. ACS CAN is grateful for the committee's invitation to speak to the issue of interstate sales of health insurance and its potential impact on consumers. Insurance issues are inherently complex and often dense, so I would like to explain the issues through the cancer lens, how the concept might ultimately affect cancer patients and survivors. Cancer death rates have decreased by 21% among men and 12% among women since the early 1990s. Despite this significant progress, the American Cancer Society concluded that its long-term goals of significantly reducing the incidence and mortality of cancer cannot be achieved unless the significant coverage gaps that exist within the current healthcare system are addressed. Although major advances have been achieved through research in the fight against cancer, too many of the advances are not being realized by actual patients because of major shortcomings in our nation's health delivery system. For example, we know that the lack of insurance coverage means later diagnosis, worse outcomes, and thus often higher costs among cancer patients. Even among those with private insurance, many cancer patients are underinsured, meaning their coverage does not provide for all the necessary and appropriate medical treatment. Many underinsured are left with the extraordinary dilemma of either incurring serious and potentially ruinous out-of-pocket financial expenses to obtain necessary treatment, or curtailing essential treatment, thereby putting their health and possibly their lives in jeopardy. The problem of paying costly medical bills directly affects middle-class families, particularly with those with chronic diseases. The overriding purpose of any insurance reform must be the overriding purpose of any reform must be to improve the nation's health for all its citizens. From a consumer perspective, interstate sales offer the theoretical potential of greater choice and lower prices. In fact, this potential will be real under the Affordable Care Act if states choose to participate in multi-state exchanges or interstate compacts. However, to work in practice, interstate sales must be built on a foundation that prevents predatory practices and unfair practices with strong consumer rights and enforcement protections firmly in place. The ACA fundamentally alters the rules of the health insurance market to work for consumers and, by extension, the nation's health and well-being. Moreover, the Affordable Care Act changes the insurance market rules in a manner that significantly enhances the competition by creating a level playing field. Among the most important changes, all insurers must provide access to coverage regardless of health status. All plans must include benefits to cover adequately a serious medical condition like cancer. Evidence-based prevention services must be included in all health plans. Financial assistance to purchase health insurance is essential for many Americans because without it, directly or indirectly, the taxpayer winds up paying the remaining costs. The administrative process of insurance need to be simplified and standardized. To have a truly consumer-driven competitive market, people must have easy and essentially free access to comprehensible information so that they can make informed decisions. These conditions exist today for virtually every consumer product, but they don't exist for one of the most important products in our lives, health insurance. Risk adjustment must be an inherent part of any private health insurance. A good risk adjustment system will reward insurers for finding efficient ways to provide quality care to all health risks rather than trying to avoid risk. This is the proper way to harness competition to the benefit of consumers and our nation. And finally, and last but not least, interstate sales that are currently built on a state-based system you must change the foundations that consumer protections do exist across state lines and there is adequate means of enforcement and redress. The general concept of interstate sales of health insurance is consistent with the overall trend in consumer products in recent years, especially with the growth of the Internet. Competition across state lines in many consumer product areas often benefit the consumers through greater choice and lower prices. So the question is, why wouldn't the same be true for health insurance? Unlike other consumer products, many insurers don't always want to sell their product to any consumer. Their business model is built around not selling to all applicants. The strategy is very simple and clear. Health claims are highly skewed. Roughly 20% of the people pay for 80% of the costs. If an insurer can avoid that 20%, they would still have a huge market, but they have avoided virtually all the cost. This in turn would allow them to provide the opportunity to sell insurance relatively cheaply to a large market of healthy people. But the side effect would be that the high-risk people, like cancer patients, are left out, are left in pools with extraordinarily high costs. The competitive pressures of unregulated interstate sales would almost certainly force insurers to embrace a highly discriminatory tactics of cherry picking. If some insurers cherry pick the lower costs in the market, the remaining insurers are left with pools that are disproportionately high risk compared to their competitors. Let me just conclude by saying it is imperative that we not jump to the conclusion that high cost of health insurance today is simply a function of too little competition or too much regulation. Interstate sales of health insurance could nominally increase competition at lower price. However, a highly competitive market without good uniform rules will simply become a faster race to the bottom. The relatively young and healthy would benefit, but the consequence would be foreclosure of access to or affordability of coverage for those with serious medical conditions like cancer. We do not believe that this is in the intent of the law or the idea, but it could happen, and that would clearly be an unacceptable outcome.
All right.
Thank you, Mr. Chairman.
Chair thanks gentlemen and recognizes Dr. Howard for 5 minutes for opening statement.
First, I'd like to thank Chairman Pitts and Ranking Member Pallone for holding the hearing today on the important topic of interstate insurance competition. I'm speaking today in my capacity as Director and Senior Fellow at the Manhattan Institute's Center for Medical Progress, from my experience writing and researching on healthcare policy issues, and from speaking to health insurance stakeholders, including large and small employers, insurers, and consumers about the challenges facing the market today. There is no doubt that the single most important issue facing American healthcare is the high and rapidly rising cost of that care, and, directly related to it, the high cost of health insurance. The high cost of care is the primary reason why many Americans lack health insurance, since they cannot find affordable coverage that meets their needs, and why more small employers are dropping coverage in the face of unsustainable cost increases. The forces driving healthcare inflation aren't the villains we hear of on the campaign trail. Bad incentives, not greedy corporations, are primarily to blame. Namely, the unlimited tax deduction for employer-provided health insurance, the dominance of fee-for-service reimbursement systems, and, most importantly for our discussion this morning, government regulations of health insurance and healthcare markets that actively deter competition that might offer lower cost but still high quality products to consumers. State insurance regulations often mandate the coverage of provider services or insurance benefits in the name of consumer protection, when in reality what such mandates provide is provider protection, or I should say provider income protection. Legislators often justify additional mandates by pointing to anecdotes where coverage of a particular service or provider appears at least after the fact to be critical to the health and well-being of a particular policyholder. But legislation via anecdote is not a justification for adding additional costs to standard insurance packages, particularly when increasing the cost of those packages inevitably prices some consumers out of the market because they cannot afford to buy the Cadillac coverage that legislators or the providers who argue for such coverage believe they must offer. Different consumers will have different preferences for insurance coverage and terms. As a 25-year-old male may opt for very different insurance than a 38-year-old married father of two. Telling the younger man that he must opt for the older man's coverage is likely to price him out of the market entirely. Creating a viable interstate insurance market would begin the vital process of making the marginal costs of regulation transparent to uninsured individuals who are in the most need of more affordable insurance options. It may also spur innovation in insurance products as states compete to offer the best combination of cost and coverage terms. This is exactly the type of competition that we should be encouraging in healthcare and health insurance markets. Objections to the interstate sale of health insurance rest on a purported race to the bottom that would supposedly ensue if consumers could purchase across state lines. However, under legislation like the Healthcare Choice Act, products sold in a secondary state would also have to be sold within their primary state. Policymakers and insurance regulators in the primary state would still have powerful incentives to ensure that such coverage sold to their own residents was not deceptive and of high quality. Also, insurance departments in the secondary state could still collect premium taxes and high risk pool assessments from plans sold across state borders, ensuring the financing necessary to maintain important consumer protections and support state high risk pools. Also, although under McCarran-Ferguson, states have the primary responsibility for regulating insurance sold to their residents, employers that self-fund health insurance coverage under ERISA are not subject to state regulation. More Americans receive coverage that is exempt from state regulation, about 90 million lives, than receive regulation that is subject to both federal and state regulation, about 70 million. Insurance regulation under ERISA has been generally light. Indeed, employers have nearly complete freedom under ERISA to design their own insurance coverage, and employees are overwhelmingly happy with the quality of employer-provided coverage. Since there has been no race to the bottom in the ERISA-protected market, it is unlikely to occur in a national market for health insurance. Policymakers should also not forget that rising health care costs are the single greatest barrier to accessing health insurance for uninsured individuals regardless of health status, and that reducing unsustainable healthcare cost increases is the single most important thing that we can do to ensure that coverage remains affordable. Mandating Cadillac coverage as the only option for individuals locked into expensive state markets is the surest way to continue the vicious cycle of cost increases, dropped coverage, and large and expensive increases in public coverage programs like Medicaid. Thank you for the opportunity to comment on this important issue, and I look forward to your questions.
Chair, thanks the gentleman. Thanks the panel for your opening statements. I'll now begin the questioning. Recognize myself for 5 minutes. Dr. Howard, start with you. Some of my colleagues on the other side of the aisle have argued that imposing an individual mandate will lower premiums for everyone by promoting larger risk pools and discouraging emergency room utilization. Have we seen any evidence of lower premiums or decreased ER utilization in Massachusetts?
No. What you've seen in Massachusetts is that ER use has actually gone up despite the expansion of coverage there to nearly the entire population. And costs have not gone down. Massachusetts insurance costs have continued to go up, and it continues to lead the nation in health insurance premiums. So it is both a highly regulated state and a high-cost state, and individuals have not been able to find more affordable coverage outside of Massachusetts' Commonwealth Care program, which is extraordinarily heavily subsidized insurance. So the market has remained very expensive. It's extraordinarily costly for both the state and individuals.
Thank you. Dr. Parente, do the regulations of guaranteed issue and community rating penalize people that have been responsible and purchased insurance before they were sick?
Absolutely. I mean, in our models and from the literature that's come up before our study, the biggest thing the community rating and guaranteed issue do is push up the premium costs. It's just automatically what an insurance actuary does when they factor in the price. And if someone had been in the insurance policy and suddenly they had a mandate that comes on that says now they're a community rated state, they're likely to be seeing a premium increase by no fault of their own of 20 to 25%, sometimes as much as 30%, just to, in effect, spread that risk by the imposition of that policy component. If you want to see that in an illustration, go to New York, where the individual insurance market has been decimated by the combination of community rating and guaranteed issue over the last 10 years.
If you would continue, Dr. Parente, would the optimum policy goal be to have a system where consumers have more choice, are encouraged to buy insurance when they're healthy, and provide a safety net to those with pre-existing conditions to be able to purchase affordable coverage through functioning high-risk pools? Would that be a lot cheaper to accomplish than HIPAA?
That would be the ideal. The logistical challenge is to make sure that the folks that are vulnerable and don't buy coverage, that lose coverage because of pre-existing conditions, have that high-risk pool that's available to them. Minnesota actually has that in place. They've had a high-risk pool designed very successfully since 1978. It's probably associated with about half of what would otherwise be folks that are uninsured because of that design. If that type of design was available more commonly across the U.S., it could actually be quite effective. What is nice about the interstate policy is what it does is it levels the playing field in terms of letting people shop freely across states, potentially electronically. eHealthInsurance.com has shown that that could be done quite easily. And then for those that may be in a vulnerable situation, as long as they're identified, they can essentially apply for premium subsidy support and essentially get it either through a state high-risk pool design or some other type of system.
Ms. Herrera, you mentioned Georgia. Georgia recently enacted a law to allow the purchase of health coverage across state lines. Can you give us an idea of how many states Georgia residents can now buy more affordable coverage from?
Absolutely. In the case of Georgia, it shares a border with Alabama, which has a relatively low number of mandates and a relatively lightly regulated health insurance market. Premiums are lower. So for folks in Georgia who are uninsured, allowing them to go over to Alabama to buy a more affordable policy would be good. However, Georgia also shares a border with Florida, which has mandate-rich coverage and many consumer protections. Folks in Georgia looking for those options could buy from Florida as well.
Could you elaborate on the effects on coverage in New York after PIPACA-like reforms such as guaranteed issue and community rating were adopted?
I'm not familiar with the New York market.
Dr. Parente, can you elaborate on that?
Actually, Dr. Howard and I did a study that came out last year that more or less showed that when those legislation was changed in the mid-1990s, it pretty much took a functioning individual insurance market with several 100,000 individuals and reduced it now to, I think, close to less than 100,000, 50,000 people in the private insurance market. There was additional state subsidy components that came in place, but the cost in New York to put that subsidy program in place ended up being net expensive and potentially putting many New Yorkers in a much more vulnerable position. When we've done simulation models using the same models in the study, showing what would happen if New Yorkers could buy from Pennsylvania and Connecticut, it potentially could reduce the uninsured for that population affected by half.
Thank you. My time has expired. Chair recognizes the ranking member for 5 minutes for questions. Mr. Pallone.
Thank you, Mr. Chairman. I did ask unanimous consent to have Mr. Green participate in the questions and answers, Mr. Chairman.
Without objection.
Thank you. I wanted to start with Mr. Larsen. Mr. Larsen, I'd like to discuss with you some of the effects that H.R. 371 or similar proposal might have on state governance in the insurance market. You probably know that Arizona Governor Jan Brewer recently vetoed legislation that would allow out-of-state carriers to sell policies in Arizona. And Mr. Chairman, I'd ask unanimous consent to enter the veto message of Governor Brewer into the record. I don't know if you have it, but
Yeah, we have it without objection, so
ordered. Is it your understanding that the proposal, like H.R. 371, would vacate the state of Arizona's decision and, in essence, overturn the governor's decision?
That's my understanding, yes.
Okay. If you Governor Brewer, when she vetoed the bill last month, allowing selling insurance across state lines, she said in the message, and that was what I just entered to the record, she said she, quote, is concerned about risks to our citizens who may be subject to other states' regulatory procedures that could leave them with little recourse in the event of mistreatment. Recalling your days when you were the insurance commissioner for Maryland, did you, for example, have enough money in your budget to assist consumers in other states if a plan licensed in your state was causing problems for them elsewhere?
It was, excuse me, always a challenge to get funding for our department, so it would have been difficult to handle the complaints from any number of other states.
Well, wouldn't we end up with more sham plans on the marketplace and more consumers in trouble, essentially?
I think it certainly creates that possibility. It's very likely, yes.
Is there anything in your experience at HHS lead you to believe that it would be a good idea for the federal government to preempt all state insurance laws subject to the whims of insurance companies?
For states or the federal government?
For the federal government to preempt all the state insurance laws?
No.
Okay. I'll ask you and also Mr. Finnan, if I could. I'm concerned that, again, under this legislation, the Ms. Blackburn's legislation or something similar, the incentive would be for insurance companies to choose to locate in the state with the least amount of protections and the least amount of oversight of the industry. So let me ask Mr. Larsen first. Do you believe that insurers would rush to sell products from the single state with least possible consumer protections and other requirements?
I do.
And then, Mr. Finnan, how would this affect the individual health insurance market in most states? As you know, a number of states require insurance companies to offer coverage to everyone in their state, the guaranteed issue, and some states require insurance companies to offer that coverage at one rate, community rating. What effect do you think that Ms. Blackburn's bill would have on those in most need of health care services in these states, for example, people with cancer?
There is no question that without a level playing field, without standardized rules across the market, there will be a race to the bottom. States insurance companies will migrate to the least regulated states. And as I said in my testimony, if without a guaranteed issue, they will cherry pick. And therefore, they will be looking to pick off from other states the best risks. They will offer minimum benefit packages. The cost will be very low. We know today that most consumers the consumer literacy about health insurance is extremely low. They buy in price, and so they see a product across state lines with a low price, and they say, yes, that's great. But the reality is, particularly for cancer patients, is they're not going to be able to buy across state lines. Insurers won't accept them. They don't have to. And they're going to be left behind in their states in smaller risk pools with much higher risks, and the cost will be extraordinarily high. Where you're going to wind up with a bifurcated system where the young and healthy can do very, very well, but those, once they become sick, wind up in high-risk pools where the access to insurance is either not available because it's denied or it's beyond their reach. But let me just end by saying the reality is that most of us sooner or later will get sick. 1 in 2 men and 1 in 3 women will ultimately have cancer. And that means that there's a good chance that, particularly for those in the individual market, someday when they most need it, they're going to be without it.
Well, let me just ask one more thing. I'm worried that the legislation, like Ms. Blackburn's, would have disproportionately negative impact on older Americans or near elderly. How would this bill affect the near elderly? What would you think it would mean?
Again, it benefits the young and healthy. But as you get older, the costs do correlate with age. As we get older, the costs rise. And in the case of cancer, cancer is a disease of the aged. And so therefore, your chances of getting cancer increases as you get older. And for people in their 50s and early 60s, pre-Medicare, this becomes highly problematic because at that point they have no choice and they don't have the means or the access to find alternatives. And we see too often many people in their 50s and 60s struggling to get through until they can get Medicare coverage.
Thank you. Thank you, Mr. Chair.
Chair, thank you, gentlemen. Recognize the gentleman from Illinois, Mr. Shimkus, for 5 minutes for questions.
Thank you, Mr. Chairman. Appreciate you all being here today, and it's really good to sit and listen because obviously there's differing views. I would just take issue, Mr. Finan, by saying that what's more critical to the individual who receives cancer, who has cancer, is when they have no insurance. That is when this whole debate is having quality, accessible, low-cost insurance, and the debate is really the mandates on issues that may not deal with the catastrophic issues of health care delivery. And in my opening statement, I did with contraceptive coverage. I mean, that prices people. You get, if it's 1% per mandate and you have 30 mandates, you have a 30% increase on private health insurance. Mr. Herrera, I love ALEC and I appreciate their position. I've got in your testimony individual health policies as low as $110.05 in Iowa compared to New York, which is $339.60. That's a huge difference. Are we saying that the folks in Iowa have sham plans? Is that a sham? No, Ms. Herrera. No, Ms. Herrera. Is that a sham plan?
Absolutely not. I mean,
you mean the folks in Iowa are not supporting sham plans that their constituents and they're not just a payoff to the insurance industry? These are quality health insurance plans that cover catastrophic issues.
That's a great point. I think that's the beauty of this kind of proposal. As Dr. Parente mentioned in his testimony, you not only have your insurance regulator, commissioner looking out for you, but you also have the insurance commissioner of the insurer's home state. And so we're adding these layers of protection as we open up the market.
And Iowa borders my state of Illinois. Illinois' individual policy averages about, and this is in your testimony, $161.15. This is a monthly. So multiply that by 12, which would show. And so the issue is affordable, accessible, quality, catastrophic coverage, unencumbered by things that you may not want to have covered. That's kind of this debate. From my perspective, obviously other people have different perspective. Let me move to.
Congressman, may
I've got 2 minutes and 30 seconds left, and I need to get to I want to go to Mr. Larsen. The Secretary of HHS, with your counsel, will be charged with determining what benefits must be in a health plan purchased by my constituents. Is that correct?
There's a requirement in the Affordable Care Act that we will define what are called essential health benefits.
So you'll be in this mandate debate too?
I'm not sure if we call it a mandate debate, but...
Well, will be if you determine what's in the essential package. That was part of our debate on this whole, why a lot of us opposed it, because if we get into now a national standard that adds mandates that the individual consumer may now be forced to purchase because of the new health care law. We're in the same boat as this entire debate.
I would say it's different in this respect. First, I would focus on the terminology. These are essential health benefits. So
Well, I think the state of Illinois has decided that contraceptive coverage is an essential health benefit.
Well,
And I would argue that a lot of my constituents do not think so, nor do they want to pay for that. So I would be very, very careful as you all move forward to make sure that it's essential. I would say catastrophic coverage would be essential. This is what you're doing now is part of this mandate debate. Let me move to another question real quick. Secretary Sebelius has stated that the fraud and abuse in our medical system increases costs. Do you agree with that assessment?
I think, yes, we can reduce costs through doing an improved job of ferreting out fraud and abuse, yes.
So part of the health care plan is going to have a huge focus on ferreting out waste, fraud, and abuse.
Yes.
And with your intention and with the Secretary's attentive focus on this.
Yes.
Good, great, thanks. With 30 seconds remaining, you also mentioned that patients in non-grandfathered plans now have greater freedom to choose their own doctor. Section 1311H of the health care law, page 78 in the yellow book it's on the table there, authorizes HHS to issue regulation that would prohibit health plans from contracting with certain physicians. Is that correct?
I apologize. I'm not quite sure what you're...
Well, I'm done. Maybe one of my colleagues will follow up, but it's page 78. The health care law is right there. You're welcome to grab it. I think your health care law will allow the HHS to deny individuals access to the doctor of their choice. And I yield back.
Chair, thanks, gentlemen. I recognize the Ranking Member Emeritus, Mr. Dingell, for 5 minutes for questions.
Mr. Chairman, I thank you for your courtesy. The French have a great saying, the more things change, the more they are the same. I've seen this before. About 20 years ago, this committee went into the matter of mischief, rascality, and interstate sales in insurance. And it was a scandalous thing to behold. And we found the state regulatory agencies didn't have the authority to address it, that they couldn't address it, and they wouldn't address it. And beyond that, we found something else. We found that folks were traveling around the country with suitcases full of cash, running off to the Cayman Islands and all kinds of other places, that places like Louisiana and Texas, next-door neighbors, couldn't deal with their problems of enforcing the laws. It was a terrible mess. And insurance ratepayers were getting skinned left and right. And commissioners of insurance came into this committee to complain about the fact that this was going on. So I can see that the insurance companies have been busy. And I can see that they are looking forward to cutting a fat hog, which this bill will permit. So I have a few questions here. So to Director Larsen, please answer yes or no. Section 2796 of H.R. 371, the Health Care Choices Act of 2011, would exempt health insurers in a secondary state from complying with any state law regarding fraud and abuse other than those that meet the definition in Section 2795. I am concerned that the definition of fraud and abuse in H.R. 371 is so high states would find it nearly impossible to prosecute an insurer for fraud and abuse, thereby opening wide the door to fraudulent activity. Now, do you agree with that statement, yes or no?
Yes.
All right. I happen to believe that H.R. 371 would increase the opportunity for rascality, particularly due to lack of enforcement authority and oversight tools, and as Mr. PALLONE has pointed out, money and capabilities to deal with these things that would be available in the secondary state. These states would be unable to revoke the license of an out-of-state insurer if they were found to be acting fraudulently. And without this type of tool to discourage abuse, I'm curious how a secondary state could, in fact, protect their constituents. Again, as a former insurance commissioner, do you believe that a secondary state would be able to audit an insurance license in another state under H.R. 371, yes or no?
I'm sorry, that they would or would not be able to audit?
Say it again?
Well, let me answer this way. I think that provision of the law would give me great pause as a former commissioner in my ability to oversee.
It would be a wonderful opportunity for rascals and rascality. Further, if the secondary state found that an insurer acted fraudulent in their state, do you believe, again, that H.R. 371 would allow a secondary state to prevent the insurance that acted fraudulently from operating within their boundaries? Yes or no?
I think it would be difficult, yes.
Now, Mr. Finn, it is clear that one of the side effects of this bill will be a race to the bottom, and insurance companies will be huddling up in the states with the most lenient regulations. For example, under current law, if a constituent of mine suffering from breast cancer has a complaint about their insurer not covering the cancer treatment recommended by their oncologist, my office could help them receive recourse through the Michigan Insurance Commissioner. I'm curious how my office would handle such requests under H.R. 371. If a constituent purchased their inadequate insurance in Iowa, am I to expect that the Iowa Insurance Commissioner is going to regulate this insurer? I happen to think that this puts too much hope and trust in the insurance industry and in a ramshackle system of regulation. I have previously told my friends on this committee this would be like using one pat of butter for a whole loaf of bread. Is it your opinion, Mr. Finnan, that you believe that one state or even a small group of states would be equipped to handle the concerns and complaints of residents of a neighboring state?
We are deeply concerned about the ability of any state insurance department to enforce or act across state lines.
Thank you. Thank you. Now, one of the biggest accomplishments of the Affordable Care Act is that consumer protections make up what is called the Patient's Bill of Rights. H.R. 371 would repeal these protections, leaving consumers once again vulnerable to lifetime limits, annual limits, discrimination for pre-existing coverage, limited health benefits, and rescissions. I tend to believe that repealing these protections would enable the insurance companies to discourage or prevent those suffering from cancer or other illness from entering their pool. Do you agree with this assessment, yes or no?
Absolutely.
Thank you. Mr. Chairman, I thank you for your kindness.
Chair thanks, gentlemen, and
got a bad bill
recognizes the gentleman from Pennsylvania, Dr. Murphy, for 5 minutes for questions.
Thank you very much. Mr. Larsen, at the end of your testimony, I couldn't find your written testimony, you made reference to that if a person has to go back to another state because they're having a problem with their insurance company, you said basically it was likely their consumer complaints or problems would go unresponded to or unheeded. Can you explain that?
I think the issue is if there's, I think the terminology that this uses is the primary and secondary state. If you are a resident of the secondary state, now you are essentially beholden to the resources of the insurance department in the primary state.
But how did you word that, though, that if you're not from that state, you felt that they weren't going to be responsive?
It's a resource issue, frankly, right? If you've got a company that's selling in 50 states from one primary state, and that primary state has to address the concerns or complaints, which you always get as an insurance.
You get that, so you feel they would be less likely to be responsive?
It's a resource issue.
Okay.
There's only so many people.
Ever been to a restaurant where you got bad service?
Pardon me?
Ever been to a restaurant where you got bad service or bad food?
Yes, I have.
Do you go back?
I try not to.
Do you tell your friends not to go back? The answer is that I think if a person goes to a restaurant bad service, they're about 12 times more likely to tell friends about it. But if they go good restaurant, they tell a few. But the point is word gets out, and that ruins that restaurant's reputation. Let me ask this. Does Medicare run things well? Because I know I've got staff that are always dealing with Medicare and Medicaid problems. As a matter of fact, I've introduced a bill to deal with some of the things that CMS has problems with when plaintiff attorneys and trial attorneys are trying to seek information, just information from Medicare with regard to how much Medicare is paid on a bill. It can take them weeks or months to find this out, and oftentimes this is an error. Now, my problem is seniors who have this issue, they have nowhere else to go. They have no other restaurant they can turn to. They have no other car dealer they can turn to. They're in a single market here where they have nowhere else to go. So along those lines, one of the things I hope you'll look into, that when an organization has a monopoly on something, there is no competition or anything else anybody can do. And that's part of what we're seeking here, is to find another way of that. So if a person doesn't like the service from one insurance company, they say, I'm not going to go back. And that information does get out. And so I would ask the other panelists along those lines, what mechanisms does someone see in this bill or something that should be added to it that if a person is shopping across state lines, that should be available for people to have information of whether or not an insurance company covers certain things or they are effective and efficient? Can someone answer that for me? Yes.
I would like to address that. First of all, health insurance is not like a restaurant. I totally agree with you. You get lousy service, you don't go back. That's the end of that discussion. Sure. But what about the cancer patient who's in the middle of a treatment, is being denied coverage that they think they're entitled to under the contract? Mm-hmm. What's the recourse? They can't go to another health insurance plan at that point. That's impossible.
Well, that's a good point, but that's a different, I understand the point. Look, I don't want anybody to be denied coverage. I don't want to be cut from coverage. That's another issue. And I do want to ask you a question about cancer, but my point is, however, I know in the Pittsburgh market, we're basically locked into two companies who cover the dominant part of the market and a couple other ones. But people don't have any other choices. So even if they say, I didn't get good service from this insurance carrier and didn't get that one, they've got nowhere else to go. So, Ms. Herrera, can you answer that? Is there any mechanism you see that states can help demand or provide along these lines?
Well, my expertise is in the area of state legislation, and in all of the states that have enacted this legislation, the primary state's insurance commissioner, the primary state's courts would adjudicate those disputes.
Well, all right, then let me go back to this cancer question, because, Ms. Fannin, this is very important for cancer, because I strongly support your concerns here. But do you see anything in this bill that prevents us from either, maybe it should be added to this bill, maybe another bill, that would deal with the issue of denial of coverage or denial of pre-existing conditions or cutting someone? Do you think that's something we still need to make sure that we address as Congress to make sure that you still can't deny coverage?
Yes. The Affordable Care Act, I mean, one of the big advances from a cancer patient and survivor perspective is that there is establishment of clear consumer rights, including, for example, the right to appeals and the clarification. This bill, as I understand it, would repeal all of those provisions. And so therefore you go back to the old system where there are...
It would repeal the provisions, it would repeal every single provision?
As I understand it, it would repeal Title I of the Affordable Care Act, which embeds all of those consumer rights. And so therefore you go back to a system where the consumer is totally confused. We see this, we have seen this all very often among cancer patients, that they're denied coverage, that they don't know how to appeal, the rules are convoluted.
Well, there is something in here on page 22 about the right to an external appeal process, so maybe we should discuss that more and review that, because I'd like to find out. Thank you. I yield back.
Chair, thanks, gentlemen. Recognize the gentlelady from California, Ms. Capps, for 5 minutes for questions.
Thank you, and I appreciate the previous 5 minutes. I don't want to keep you on the hot seat, Mr. Finnan, but I'd like to continue this conversation about chronic diseases. When most people think about individuals who can't get health insurance coverage because they are sick, they do think about individuals with catastrophic illnesses like cancer or AIDS or multiple sclerosis or any number of debilitating progressive conditions. Mr. Finnan, I'll give you a little more time to amplify for us some of the difficulties you have documented in cancer patients getting insurance and accessing treatment once they have insurance, and the challenges that would be posed by this bill as you understand it.
What I stated in my statement and are absolutely essential are the common rules. There needs to be guaranteed issues so that insurers are not discriminating. That helps level the risks and level the costs. Insurance is about cost sharing. It is about sharing risks. I mean, I've had homeowners insurance for 30 years that I've never collected, but I'm perfectly fine with that. But, you know, in health insurance, we know sooner or later that most of us will experience a serious claim. And so we have to set the rules so that that cost is spread. It is essential to have essential benefits because too often, and we see this increasingly often, where patients don't get in the middle of treatment and then they realize they've run out of benefits.
Right. Let me just ask you, because we're faced with two choices. We have the law now that the approach that, as you understand it, under the Affordable Care Act, but now the Health Care Choice Act. How would you contrast the ramifications for people with cancer? Do you believe that the protections on access to coverage would be eroded under this bill that's before us?
Oh, very quickly. There's no question.
Just highlight a couple of the areas, if you would.
Well, again, it's going to be it's a race to the bottom. And then the insurers are going to sell weak benefit plans at a relatively low cost to relatively healthy people. But it leaves behind...
And if you become sick, because a healthy person can have a diagnosis with cancer and then life changes in an instant before their eyes.
And that's correct. And then all too often insurers engage in practices that force people out. There have been rescissions. This committee has done a lot of excellent work in that area. And where do they go? And then they wind up in pools that are extraordinarily expensive. I know of an example of a few years ago of a woman who moved from Alabama with insurance, wanted to move to Virginia, which is an insurer of last resort, which says that means the Blue Cross there does have to provide insurance, but they can rate based on the risk. And a woman with breast cancer had completed her treatment, was given a premium of over $60,000 a year. And if you inflated that to current costs, it's probably more like $75,000 to $80,000 a year. That's what will happen to cancer patients under this kind of system where you bifurcate the risk pools.
And cherry pick the...
Yeah, the cherry picks will be, they'll get great prices. But people with chronic conditions like cancer are going to wind up with extraordinarily expensive insurance.
And like you say, the reason we have health insurance is to protect us if something catastrophic happens. Yes. Mr. Larsen, I want to use the rest of the time to talk about the difference between, talk about what states' rights involve. You highlight in your testimony that this bill would create an unlevel playing field where some of your constituents are protected by the laws in their states and some are not. In addition, you note that this bill would undercut the authorities of state governors, state legislators, and insurance regulators. So states' rights are out the window, something that most of our colleagues on the other side of the aisle often point to as a reason to block grant Medicaid or repeal the Affordable Care Act. What would this do to consumers? How would it ultimately hurt them, or if it would?
Well, I think it would, and it's a huge change. I mean, compare the resources that different insurance departments have. I think the state of Texas has 20 times the staff as a state like Idaho. So if for example, an insurer decided to use as its primary state a lightly regulated state with very little staff, it's hard to imagine how that staff could handle essentially regulating products that might be sold in 50 states.
How would you imagine a state insurance commissioner, that's something you know about, how would that state insurance commissioner punish abusive insurance companies that may be located in another state?
Well, again, if you don't have the authority over the company that is selling to your residents,
you have no control.
Certainly you can, talk to the other insurance commissioner, but at the end of the day, if they're selling products legally under a proposal like this in your state, and they only have so many resources and so many laws, because it's not just the resources, it's the consumer protection provisions.
And wouldn't most of the insurance companies want to locate it in a state that had very few regulations?
Well, I mean, I think that's the purpose, to sell your policies out of a lightly regulated state, both from a resource standpoint and certainly from a benefit requirement. You're going to be selling, thin, light policies in my state. My healthy young people will gravitate to these policies, and it will essentially destroy the risk pool in my state, and I can't do anything about it.
Thank you, Mr.
Chair, thanks, gentlelady. Recognize the gentlelady from Tennessee, Ms. Blackburn, for 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate so much that you all are here to talk about this issue. This is one we have talked about for a good period of time. And at the core of it is, how do you increase access to affordable health care insurance and affordable health care delivery for all of our citizens? Now, there are a couple of ways that we can go about this, but I find it very interesting that there are some in this room who seem to believe that individuals can't make their own decisions about health insurance, that it is going to take the federal government. And I find that very sad. I think that most people find a product that works for them, and they're knowledgeable consumers, and they want to go out and buy the best that they can afford. We see it in other sectors of the free market system. Mr. Finan, did you read the bill?
Yes.
You read the bill?
Yes.
Okay. I would encourage you to go back and read the portion where, and Mr. Parente actually spoke to this, you not only have your primary state, but your secondary state assurances. Mr. Parente, would you like to elaborate on that point when it comes to consumer protections?
you have both states behind having your back, basically, which is better than just having one state. And yes, you have the issue of essentially whether the state insurance commissioner does have the resources to be able to do this. But understand that if insurers start to migrate to that state, and that insurer pays taxes because they're migrating to that state based on their revenue, guess what that insurance commissioner office is going to do? Staff up. You're going to set up a competition amongst the states on who wants to actually have the insurance companies operating in their parameters. And to restaurant comment, do a good job. So to the issue of cancer and chronic conditions, one thing that I'd like to point out that's in this study that we looked at that was discussed in the previous committee hearings, if you have a chronic condition and you have cancer, you're better off under an interstate provision than the status quo. And the status quo will take us to 56 million uninsured by 2014. This law that's being discussed, or things like that, addresses those people with cancer and chronic conditions today, not in 2014. How can you say to somebody from 3 years from now, it's okay for you to die because you can't have insurance coverage because we have to wait for the law to come into power?
Okay, Ms. Herrera, let's talk about state insurance commissioners and legislatures. Do you find that they evaluate the cost of the mandates before they implement them, or do they put them in place and then to do a review?
In about 28 states, they have what's called a Mandated Benefits Review Act, which requires a cost-benefit analysis for proposed state mandates before they take effect.
Okay. As a practical matter, and Mr. Howard, let me come to you on this, because I think that some of the research work you all at Manhattan Institute have done. As a practical matter, insurers have to offer policies that consumers are willing to purchase. We know that, and I believe consumers are pretty savvy. Shouldn't they be able to determine which type benefits that they want, that insurers are willing to buy, that they can go to one of the states which has offered a certain set of mandates, a certain set of benefits, and then make those choices knowing that they're going to have that benefit review in that state, find a product that fits them, and then be able to move that into the marketplace? So shouldn't they have the ability to make that decision?
Absolutely, and I think that what we need to think of this is as a dynamic system. So no state is going to want to have the reputation of being a fly-by-night state where they were allowing terrible or abusive insurance practices. They'd in effect want to become the Delaware of insurance, where they'd want to have the reputation for the best solvency requirements, the best consumer protections, and the most affordable policies. So states would have powerful incentives to attract consumers, as Dr. Parente just pointed out, for reasons of accruing premium taxes, to have the right mix of coverage that was both affordable and
Thank you
chronic
for that.
questions.
I've got another question. Mr. Larsen, your testimony praises PAPACA for supposedly aiding children with pre-existing conditions. Yet what we have seen in some surveys since PAPACA was signed into law is that the carriers are no longer offering child-only health policies in 20 states. The so-called protection for children with pre-existing conditions has turned into a nightmare, an absolute nightmare, where many parents cannot find coverage for their children at all. Do you believe that that is an acceptable outcome?
Here's what I would say. We have
Yes or no?
We have stopped the process. We tried to stop the process of insurance companies not providing coverage to sick kids, which they actually agreed to do and then decided that they didn't want to do. And we have given them every tool possible in terms of open enrollment, rating options, everything. And I think
Do you find it acceptable that that premiums have increased on young adults 17%? AP reported that young adult health premiums have increased 17% because of the new law. Do you find that acceptable?
Those certainly aren't the numbers that we have seen, and I'm not familiar with that.
I'll be happy to supply you with the article, and I yield back.
Thank you.
Chair, thanks to the gentlelady. Recognize the ranking member of the full committee, Mr. Waxman, for 5 minutes for questions.
Thank you, Mr. Chairman. I find this bill like a bad penny. It keeps on coming back, and it doesn't make sense now, particularly since we have the Affordable Care Act. The Affordable Care Act was supposed to deal with the problem of people who have pre-existing, one of the big problems, people can't buy insurance. and they can't buy insurance in the individual market often because they have pre-existing conditions. Dr. Howard, would this change the practice for pre-existing conditions if an insurance company still wanted to discriminate?
You know, in states that have implemented both community rating and guaranteed issue, like
No, I'm just asking you, is there anything in this bill that would prevent denying coverage because of pre-existing coverage, pre-existing conditions?
it would allow people to buy insurance that was more affordable to them. It would give people more options to buy insurance.
Well, what if the insurance companies didn't want to cover them because they had pre-existing conditions?
Insurance companies that didn't offer coverage or offered unaffordable coverage should have the option of state high-risk pools, federally funded, hopefully, to have that option.
But that's not in this bill.
Well,
that's not existing law. Now, let me go through rather the abstract of some of these issues. Let me get into some details. Dr. Howard, do you believe that insurance companies should cover the adopted children of their policyholders?
If they would like to pay for that additional coverage. So if people want to pay for additional coverage, it shouldn't be mandated that everyone has to cover that, which just passes costs along to other consumers.
You don't think it's appropriate for states to require coverage of adopted children the same as their other natural-born children? In fact, I can't imagine how anybody could justify an insurer not covering adopted children in the same way they cover other children. The Blackburn bill would end that protection that's been adopted by 45 states. Dr. Howard, do you believe that insurance companies should be required to cover disabled dependents, such as disabled adult children living with their parents?
I believe that states that have those requirements. The problem is that insurers will offer any benefit to consumers.
If you could buy anything if you have the money, but there'd be no requirement that the insurance companies cover disabled adult children. Disabled adult children, often unable to work, would have nowhere to turn for their health care unless they could be covered under their parents' policy. Nowhere except, of course, Medicaid, which the Republicans are proposing to destroy. The Blackburn bill would eliminate this protection that 42 states have chosen to cover. What about coverage for well child care?
States that in this market, that we move to an interstate insurance market, individual states will decide what the best mix of coverage is. So for things where it's disabled children or covering adopted children, a state would say that's a valuable policy, we're going to keep that.
Can they mandate it?
If one
they can't require it. Some other
of course
policy approved in Iowa must be sold in the state of Nebraska. Isn't that right? And if that policy doesn't cover it, and other policies decide, well, they've got to compete with this cheaper policy, and they stop dropping coverage, the state has no ability to mandate it. Is that right?
That's correct. But
okay.
They have
now, what about this coverage for well child care? This is now guaranteed by 34 states that help healthy babies stay healthy. And that would be eliminated. 34 states have required it, and this would be eliminated. Do you believe insurers should cover diabetic testing supplies to make sure the diabetics can manage their diabetes?
Congressman, I believe what would happen is that insurers would look at individual mandates on a case-by-case basis and say, does this add value to the policy and help keep our individual policyholders healthy? In many cases, they may keep some of those mandates. They're likely to get rid of mandates.
In other words, the insurance
right
companies will decide if they, the insurance companies will decide if they want to cover that, and they won't be told they have to, only if they think it's something they think is part of the package they want to offer.
That gets consumers to buy their policy.
Yeah, but if consumers don't have a choice of any policy that covers it, then they just have to buy whatever is available. This particular requirement on diabetic testing supplies has been guaranteed by 47 states, and that would be eliminated by the Blackburn bill in those states. And I could keep going. Emergency care is required in 47 states. Alcoholism, substance abuse treatment, 45 states. Maybe an insurance company would decide that's too much and they don't want to provide that. Colorectal cancer screening. Out of the munificence of an insurance company, they may decide that keeps people from getting colon cancer. But it's cheaper to sell a policy that doesn't cover that. Cervical cancer screening. And we can go on and on. I must say, Mr. Chairman, that I find it amazing when people quote the wisdom of Dennis Hastert to say, you don't force them to buy a Cadillac. If we don't allow people with pre-existing conditions to buy anything because there's nothing available to them, they won't even be able to buy a jalopy. And I'm always amazed when I hear people say, we're going to give people the freedom. You give them the freedom to buy something that won't be available to them because they can't afford it or it's just not even offered. So I yield back my
Thank you. Mr. Waxman, I yield to the gentleman from Georgia, Dr. Gingrich, for 5 minutes.
Mr. Chairman, thank you very much. I am going to turn to Mr. Larsen. Mr. Larsen, would you explain to us again what your position is within the Center for Medicare and Medicaid Services, what your title and your responsibilities are?
Sure. I'm the director of the Center for Consumer Information and Insurance Oversight, and this center focuses strictly on the private market health insurance reforms with the Affordable Care Act. So exchanges, implementation of the MLR provisions, rate review. We do not handle. A different center handles Medicaid, and a different center within CMS handles Medicare.
Right.
We're strictly the private market.
Thank you for clarifying that. Well, in your testimony, you state that because of the Affordable Care Act, sometimes referred to as Obamacare, that most insurance companies cannot discriminate against someone because of pre-existing condition. And you go on to state that, and I quote, "We have also prohibited insurance company rescissions, so most insurers can no longer cancel coverage when individuals get sick just because they may have made a mistake in filling out the application, doing the paperwork." In all, you use the phrase most, the word most, 8 times in your testimony when referring to insurance plans or companies. I'm curious, Mr. Larsen, which insurance plans do not fall under the protections you praise for the Affordable Care Act? You say most, not all, but...
Yeah, I mean, I'll go back and look. I mean, the nutshell version is that, for example, rescissions, which is one of the provisions that takes effect now, that's in effect today, that applies to all insurers. And then when we get to the exchanges in 2014, the prohibition on pre-existing conditions, exclusions, and exclusions, you know, based on health status will disappear.
Well, let me interrupt you just for a second. Would you say then that maybe one particular plan that's not covered is the Medigap plan, the Medigap plan that's offered by AARP, which controls over 30% of that market? My reading of the bill suggests that they're not really covered. You don't have jurisdiction over the Medigap plans that are offered by AARP. Is that correct?
Not in my shop, no. There's a different set of rules that apply to the Medigap plans and the conditions under which they have to be issued. So we don't deal with the Medigap in the exchanges.
Well, are the Medigap plans, for which we all know in previous testimony that AARP reaps a pretty significant profit, royalties they call it, are they subject to these same consumer protections that you talked about in regard to?
There's a whole different set of protections and provisions that deal with the Medigap policies. And so, for example, the Medigap isn't part of the private market reforms that we're talking about.
Well, the fact is, of course, that AARP, the American Association of Retired Persons, who promotes and markets this Medigap policy for a particular insurance company from whom they receive a lot of royalties, since it's 30% of the market, that they were granted an exemption from a lot of this oversight and regulation. Who knows, I mean, whether that's a political support sort of thing, a reward for endorsing Obamacare. But help me understand something else. You're here today testifying on behalf of the administration that without Obamacare's consumer protection, cross-state purchasing is a bad idea, and yet seniors under Medigap plans are not afforded those same protections. Yes or no?
Well, I can't really speak to kind of the details of the Medigap.
Well, I can speak yes or no, and the answer is no. Do you believe that seniors under Medigap plans should enjoy the same consumer protection as younger Americans?
As which Americans?
Younger.
I think anybody in a Medigap plan should have the right to consumer protections. And what those are compared to what other policies are, I can't get into.
Can you explain to me why seniors were not given the same consumer protection under the Affordable Care Act as young Americans?
Yeah, again, it's a different regime. The Medigap are supplemental policies to Medicare as opposed to policies, issued in the commercial market.
But wouldn't you agree that they deserve the same consumer protections as any other Americans?
They may get them. I don't.
Mr. Larsen, the Obama administration and the congressional Democrats cut over $500 billion out of Medicare to help finance Obamacare. And Obamacare is not Medicare. It's a new entitlement program, maybe an entitlement program for younger people. They didn't provide consumer protections for seniors that were afforded to every other American. It's hard to ignore the fact that this administration purposely rated Medicare to fund a political takeover of health care and quite simply ignored the needs of seniors in the process. And now the solution, they say, is iPad. If you think that the first raid was bad, wait till you see the second. And I yield back.
Chair thanks the gentleman and yields 5 minutes to the gentlelady from Illinois, Ms. Schakowsky, for questions.
Well, that's interesting that the gentleman is criticizing the Democrats on Medicare when he and all but 4 other Republicans voted for a plan that essentially ends Medicare. It could have a different name, but it won't be Medicare. Guaranteed benefits for the elderly. I wanted to clarify something else, and that is the Affordable Care Act, as I understand it, does include a provision to allow insurers to sell insurance across state lines and only be subject to laws in the issuing states, but that there's also a provision known as the Healthcare Choice Compacts that includes a number of protections for states and for consumers. So policies are not, insurance companies can sell across state lines under the Affordable Care Act. Am I right?
There is a mechanism to do that. The only difference is it doesn't result in the preemption of either state's laws.
Right. So the state laws that were cited by Ms. Herrera, I think you mentioned Georgia, Maine, Wyoming, maybe some others. Those laws would, under the bill we're talking about today, would be preempted. They would be eliminated. Am I right? And under the Affordable Care Act, those states would be able to maintain their laws.
Right. We get the benefit of interstate sales without the problems associated with one state preempting the laws of another state.
I really wanted to clarify that, because I think we're talking about it as if the Affordable Care Act doesn't allow for states to sell policies. We just do it with the interest of consumers in mind. Mr. Finnan, is it Finnan or Finan?
Finan.
Finan. You seem anxious to respond to comments or questions that were raised by my colleague from Illinois. And I wanted to let you do that, but I wanted also to clarify something else. Mr. Parente said, and it is true that some of the protections of the Affordable Care Act don't go in place for 3 years. And so, he's saying that right now cancer patients can just die or something. But does this bill really protect cancer patients? So if you could say what you wanted to say, and then also...
I just wanted to go back to the gentleman from Illinois who has left, but he said cancer patients should be most concerned about uninsured. We are obviously very concerned about that, but the problem of underinsurance is an extremely important one too. And we do see this, and it's becoming nefarious, where patients are in the middle of treatment, realize that their benefits have run out, that they simply can't go to the doctor anymore, or they can't get more treatment because it's not covered.
So it's not like they can pick another restaurant.
No, exactly.
Thank you.
That's exactly the point. I'm sorry, what was your second question?
The second question was that while it is true, and for some people I'm sure troubling, that the Affordable Care Act's full provisions don't come in for another 3 years, do the provisions under this bill provide the kind of protection that you need?
Well, first of all, some of the provisions of the Affordable Care Act have kicked in. We do have extension of the dependent coverage. There is no ban on lifetime limits now. There are raising of the annual limits. So some of the benefits have kicked in. There is a transition. But to the point is, if we didn't have the Affordable Care Act, we would be in a worse place. We'd go back to the pre-Affordable Care Act where none of those provisions are in place. So the Affordable Care Act is moving in a...
But would this bill
No, as I understand the bill, it would essentially go back to the world of protections that we had before the Affordable Care Act. And in fact, it would exacerbate it for all the reasons I said. You wind up with a race to the bottom, and you wind up with cherry picking, which makes things that ultimately would wind up with a worse situation than we had before.
And let me just finish with this. As a former state legislator, we worked very hard on both sides of the aisles to put in the consumer protections that are in our state legislation that range from mammograms to all kinds of things that we thought should be available in our state. And that's true, and Mr. Waxman enumerated many that are so popular that 40, 45 states have those. Those, as I understand it, Mr. Larsen, would all be eliminated if those state laws were, if there were something from out of state.
Sure. If an insurer picked as its primary state a state that didn't have those benefits, and there are a small number that don't, then yes, that would set the standard or the ceiling for all other states in which those policies are sold, and you would not get the benefit of those.
Thank you. I yield back.
Chair, thanks, gentlelady. Recognize the gentleman from Louisiana, Dr. Cassidy, for 5 minutes for question.
Hey, folks, I have 5 minutes. I've interrupted you. I'm not being rude. I'm just trying to maximize. Dr. Howard, Mr. PALLONE spoke glowingly of how New Jersey regulates, protects consumers, et cetera, and they don't want to race to the bottom. What I see, though, from your excellent testimony, Ms. Herrera, is that the premiums for somebody with an individual policy in New Jersey are about 40% higher than in Pennsylvania. New York, which also has banned community rating, I suppose, and guaranteed issue, it is more than double. What is going to be the impact upon insurance? What is the data? Everybody's talking about how they feel. I want data. What is the data about doubling a premium and what that does to your rate of uninsured?
I defer to Dr. Parente on the exact numbers. But
Dr. Parente?
I mean, basically, if you have premiums that are substantially less, obviously more people are going to get coverage. I mean, that's the best way to deal with it.
So if you lower premiums by 50%, that would have a significant impact on the ability of people to get good coverage, correct?
Yes.
And data shows that, correct?
Yes. That's what the study shows. That's what we're trying to say.
Mr. Finan, we actually have empiric data. We know that ERISA plans have few mandates, no cancer mandates that I know of, and yet we know that they, if you will, are can be compared to plans which have lots of mandates, including some ERISA plans which are governed by state insurance companies. Is there any difference that you know of, data, not feelings, but data that you know of, in difference in cancer outcomes between those covered by ERISA plans without mandates and those covered by plans subject to mandates?
I do not know of any specific data, no.
I didn't think so. So in fact, much of what you're saying is kind of an existential anxiety. I'm not sure you actually have data to show that the mandates improve. Just comparing ERISA to non-ERISA, no mandates to mandates, I'm not sure you have that data.
But the problem is...
No, I'm sorry. I'm really into data right now. Dr. Parente or Dr. Howard, checking for your PhDs, I'm sorry. Mr. Larsen suggests that community rating keeps the young and healthy in the market. He kind of painted a catastrophic, oh my gosh, if we don't keep them in the market, terrible things happen. Can you elaborate, maybe it was you, Dr. Howard, what happened in New York State to the rates of uninsured among the young when they put in community rating?
The market collapsed.
I'm sorry, what did the market do?
The market collapsed.
And that is not an existential anxiety, that is data, correct?
That's correct.
Okay. Can you want to elaborate a little bit more?
Yes, as recently as 2000, I believe, there were over 128,000, 130,000 people in New York's individual direct pay market. Today there are fewer than 30,000 in that market, and people recognize because costs have skyrocketed and young and healthy people have had to drop out of the market.
So we went to this highly regulated market that theoretically is going to provide protections for people. You say the market collapsed.
Theoretically, it's supposed to get people to stay in the market, but since young people are very cost sensitive, they drop out.
Okay, gotcha. And obviously one thing that was a problem that PPACTA had to address was the problem of the disproportionate rate of the lack of insurance among the young. If you will, we created the problem that we then had to cure. Dr. Parente.
Yes.
In your data, in your paper, you suggest that Alabama would be really at a competitive advantage because they have few mandates.
That's correct.
I was thinking, Mr. Finan is discussing the woman that moved from Alabama to Virginia, had to drop her policy apparently because she was no longer allowed to purchase that from Alabama, and so was faced with a large increase. But in your paper, you would suppose that Alabama would begin to sell. If you will, she would have been able to keep her policy. The more robust we have interstate commerce, the more likely someone could continue to keep their policy upon which they were, correct?
That is correct.
Oh, okay. That's pretty interesting. Now, Mr. Finan, I just see you biting your lip. I mean, I know you want to respond to me. What would you say, man? And I only got 59 seconds, so I may cut you off to respond to you.
Going back to your ERISA issue,
Gotta
there's
talk
apples
fast.
and oranges. I mean, the problems, the most severe, for the most part, large employers, whether they be self-insured or have commercial insurance, do a very good job, or a relatively good job, of covering serious conditions because they can spread the risk. They have a large number.
But yet, if we have somebody who's interstate, we actually have the ability to share risks. And some of the concerns you and Mr. Larsen had actually don't pertain to this bill. We could easily have an anti-rescission bill in here. We could easily have other things that you're postulating would be a problem.
But the fundamental difference is in the individual market, you're selling to individuals. You're not selling to large groups. When you sell a plan to a large group of 5,000 or 10,000.
We could have a guaranteed renewability.
Pardon me?
We could have a guaranteed renewability. I mean, that could be added.
But you're not going to sell in the first instance. If you're an insurance company, you are looking at the individual and his or her risk at the point of enrollment. If that person has cancer or a history of cancer, the insurance
No,
company,
they're
are
actually
going to
if
seek
you
to
look at the
deny
experience in
coverage.
Holland, they actually are companies that specialize in people that are high risk.
I'm sorry, which company?
In Holland. If you actually look at the experience in Holland, there are actually companies that make a living specializing in those at higher risk. The market will respond. I yield back. I'm out of time.
Chair thanks the gentleman and recognize the gentleman from Texas, Mr. Green, for 5 minutes. Oh, I'm sorry. I'm out of order. Mr. Guthrie for 5 minutes.
Thank you, Mr. Chairman. I appreciate it very much. Look, to Mr. Larsen, Mr. Finan, the concern, the major concern, there are several concerns you've voiced, but the major concern you voiced is that if a state with low mandates came into Kentucky has 34 mandates, I believe, and offered health insurance, and the young, healthy would purchase that health insurance, and therefore you would, in matter of fact, to quote Mr. Larsen, destroy the risk pool. And that's your major concern. So, it's acknowledging that people are sharing cost as we went forward. And you also mentioned, Mr. Finan, that you had homeowners insurance, which I have as well. You paid 30 years on it. I paid for quite a while. Because we have the risk of something happening, I want to be covered for a calamity. However, if I could purchase homeowners insurance when my house was on fire, or when it was burning, or when a tornado was coming, that change, you wouldn't have paid for 30 years if you could have bought it when you needed it.
Absolutely.
And that's, so when Mr. Larsen talks about the market working with the exchanges, I think you're going to have the exact same problem that you're talking about here with the Health Care Act. If you're 27 years old and healthy, and you're going to have a list of mandates that you guys are going to subscribe because you're going to have essential health benefits if you call them that. And you're going to have to pretty much match the most expensive state, because if you don't, all of the lists that Chairman Ranking Member Waxman listed, all of those, if a state goes beyond what you offer, the state has to pay for it. They have to actually subsidize those coverages. So either you're going to sit here and listen to a list that he's going to read off about you not covering, you're going to cover everything. So my point is, I see, and I don't see how you can get around, the premiums are going to increase for anybody because of the Health Care Act. It has to. And therefore, if you're young and healthy and you get guaranteed issue and you get community rating, if we've seen it in New York, we have examples of it happening, talking about data, what's going to happen to the young and healthy? They're going to drop out of the market. Now, you have the mandate to buy, but if my math's correct, I think it's a $600 fine plus 1% of your salary. So if you're a 27-year-old engineer making $50,000 a year healthy, you can pay $1,100 fine, and the most expensive state, I think Massachusetts, is $14,000 a year health insurance, and this even factored that back down to $10,000. So I can pay $1,100 fine or $10,000 health insurance policy, And if I need health insurance, matter of fact, I think if you could tell your anesthesiologist just before he puts you out to let you make one last phone call to your health insurance company to buy health insurance. But I think that's allowed. That would actually be allowed in the law. And I don't see how this whole argument about this bill destroying the risk pool, how does the Health Care Act not destroy the risk pool under that scenario?
Well, you're still going to have coverage options with the various levels within the exchanges for individuals. You are going to expand the risk pool, which is a good thing. The problem with these proposals is the risk segmentation that we get into.
But why would a young, healthy person purchase health insurance with guaranteed issue? In New York, you've seen it. You've seen it. I mean, why would a young, healthy person under PPACA purchase health insurance when the fine is $1,100?
People are going to have the opportunity to get comprehensive, affordable care in the exchanges. Even the CBO estimates that the exchanges are going to reduce administrative costs for insurers because they're not going to have to spend the time and the money and the resources underwriting people and setting up rating rules to exclude sick people. So it's going to be an attractive option.
But if the premium is not somewhere close to the fine, well, $1,100 a year, on my scenario of $50,000 a year of if the premium's not somewhere close to that, and you can get it when you need it, why would you buy it?
So I think people want comprehensive health care.
But they can get it if they need it, as opposed to paying $10,000 a year. I mean, why would somebody under that scenario that's laid out in the health care buy health insurance if they're a young person? I mean, that's the problem. That's a major problem with the law. The guaranteed issue, you cover the mandate to buy is covered by saying if you don't buy it, then you got to pay a fine. But I don't understand if the market's going to work as you've seen in New York. I don't know if New York has a fine, but people can drop out of the market and pay the fine. I don't understand why you're not going to have the same problem under the Health Care Act on a national scale that you're talking about having by letting people having mandate-like benefits to purchase. Why that's not going to happen. I mean, I just don't see how that's not going to happen.
Yeah, I think you're going to see people that want to get comprehensive coverage through the exchanges.
But I believe they can buy it but the guaranteed issue, why would they do it? That's my point. Why would a healthy person young do it?
There's a lot of people that can't get their coverage today. I mean, that's the issue that we're dealing with today, which is the broken market, right? Where
but it's still going to have a different risk pool because if you're young and healthy and you drop out, then it's going to be more expensive, and therefore more young and healthy will drop out, so it becomes more expensive. I'll yield back.
Chair, thanks, gentlemen. Recognize the gentleman from New York, Mr. Weiner, for 5 minutes for questions.
Thank you, Mr. Chairman. I think actually, you know, this is an interesting conversation about whether or not you should have insurance regulated by states. And I think you can make a pretty good argument that maybe there should be something that should be governed nationally. Now, I'd be interested in knowing whether my Republican friends would be interested in the repeal of the provision that essentially permits insurance companies to operate outside many of the antitrust laws because they share information. The argument always was let them share information because it's important for their business model to be able to do it. But I actually think that most citizens, when you ask them, do they want, if they live in Tennessee, to have Blue Cross of Utah covering them, there's a practical reason why that doesn't happen, right? If you're Blue Cross of Utah, you have to hire get a lot of people in your program that are Tennessee doctors. You don't want to go to a doctor in Utah. You're shaking your head no, Dr. Parente?
Yes.
That you think that patients in Tennessee would like to have a doctor in Utah.
I'm saying if they're in an ERISA plan, or more likely if they're a federal employee that's living in Tennessee, they're already working through United Healthcare, GEHA, Blue Cross Blue Shield National Association, getting a national provider
but
panel.
Blue Cross of Utah, let's assume for a moment I'm in Tennessee, let's say Chattanooga, and I have a doctor in Provo, and I'm sick. It's a long flight, I think. It's going to be a pretty long flight, so I'm probably going to want a doctor in Tennessee. So Provo, the firm in Utah is going to have to set up some kind of a plan for Tennessee, right? They got some doctors, right?
No, they're going to have a reciprocity agreement with the lease network.
So frankly, you do want to have some level of state regulation on where people are going to be operating. But I do think that if you really want to have interstate ability of people to buy interstate, then you definitely like what you saw in Obamacare, because by establishing basic standards that allow a foundation that we can all kind of compare, which is the fundamental notion here, is that we should be able to compare these products, we should have access to them, interstate compacts could be formed, maybe even someday a national compact, although I think that would be offensive to the sensibilities of many of my Republican friends. And frankly, you're much closer to having this. But the real objective has to be, it has to be something that someone in New Jersey wants from someone in Tennessee. And the effect of the law, that if this were to become law, is that basically you're saying to the to a citizen, you're going to outsource your rulemaking and your regulatory structure to another state. Why even have the states? Why have the states be involved in the insurance market at all then at that point? Why not just get them out of it completely and just regulate it nationally? I mean, is that the position of the panel? I mean, I guess it would be an intellectually consistent position to say to do that. Like, why do the states even have to be involved here at all? The reason the states are historically is because it's thought that, that you needed some consumer protection to be done in the state level. That you'd be able to call your local state attorney general or your state insurance commissioner and say, I got a beef with this insurance company and how they're treating me. Under this law that we're considering today, this bill that we're considering today, it's my understanding that what will happen is you're going to have some authority of the local guy to call Tennessee and say, hey, stop violating my citizens' rights. But that's really it. You're not going to really be able to march into Tennessee and be able to get, I guess you can sue them in Tennessee court if you want. But this is another instance where my friends want to take, they did this last week with their tort proposal, they want to remove the state's authority to govern this stuff and to govern their own citizens. And it's a strange place that they are. They always talk about the 10th Amendment. They talk about the needs to the rights of states. And what you're doing now is not only taking rights away from states and giving to the federal government, which they did last week with the tort reform proposal, but now they're saying give it from one state to another state. And I think that's truly problematic. But if you do believe in the idea, and I kind of in a general sense, I believe in the idea of like having more ability of people to purchase products that are more advantageous to them. But I don't believe that I should outsource New York's authority to govern insurance to Texas or to New Jersey. And I think that my state legislature, for all its weaknesses and flaws, I want to vote for them, and I want them to have the power to pass laws. My state insurance commissioner is appointed by my governor. I don't think that's outside the realm of what is practical. I mean, what it really comes down to is my Republican friends, they don't have a consistent thrust on what they don't like about health care reform. They just know they don't like anything that is being done presently by the people who are trying to fix it. And I think that's evident here today. Thank you, Mr. Chairman.
Chair thanks, gentlemen, and now recognize the gentleman from Texas, Mr. Green, for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you and the ranking member for allowing me to wave on. Mr. Finian, I know we're discussing the Congresswoman Blackburn's bill. There's an old saying that an ounce of prevention's worth a pound of cure, and I'm concerned this proposal may actually raise health care costs overall, as many individuals who need preventative care don't get it. And a good example, some cancers can be treated early if detected early with better results for the patient's health and lower cost. Colorectal cancer is one of the examples. According to CDC, 9 out of every 10 people whose colorectal cancer is found early and treated are still alive 5 years later. If everyone aged 55 or over had regular screenings and all precancerous polyps were removed, as many as 60% of the deaths from colorectal cancer be prevented. Could you please comment on how this legislation will worsen health care outcomes for individuals with cancer and raise health care costs overall?
Yes, thank you, Congressman. That is an extremely good and important question. I mean, the healthcare system today, or up until today, has given way too little attention to prevention and screening. We, the American Cancer Society and the Cancer Society Action Network, have fought vigorously to expand mandates in states on mammograms and colonoscopies, for example, because they are proven. I mean, they are cost effective in reducing cancer. If people get screened properly and according to guidelines, they're much more likely to be detected at an earlier stage, and therefore they're likely to get better treatment. But as I understand the way this bill would work, interstate sales would not be required to cover those screenings, and so we would be taking a huge step backwards in terms of addressing chronic illness. And chronic illness is the major driver of health care costs in this country.
My other question, and this is for the whole panel. Ms. Finian, one of the problems you mentioned is in those that are uninsured and receive a diagnosis for cancer. You also mentioned that even insured people, 25 million, face major struggles paying their bills now. How is it that people with insurance are not able to cover their health care costs? And I know there's lots of different products out there that, you can buy a $25,000 plan. And if you have cancer, $25,000 may not even cover your first surgery. Can you talk about how folks who have insurance and are not covered by that insurance for their treatment, and particularly in cancer?
Well, because today there is no such thing as an essential benefits package, insurers can offer a wide variety of sources, and some will argue that that provides choice. But the reality that we have seen all too often is cancer patients who get in the middle of treatment all of a sudden discover there are limits within their plans. They can only go to the doctor X number of times, or there's no coverage for anesthesiologists or something in network. And one of the very serious problems we have is the lack of transparency insurance. Most consumers buy insurance because of the cost, but they don't have any understanding of what's in the benefit package. They don't know how well it will cover them if they get a chronic disease like cancer or a heart disease. And one of the great advances of the Affordable Care Act is much more requirements to increase transparency, to force insurers to disclose more information, and to provide consumers with more information.
Well, and I understand because up until the Affordable Care Act, typically insurance was a state product, except for ERISA, and I have a lot of companies who come under federal law, and there's no essential benefits under ERISA either. And there have been problems with some of my large industries, but most states make up for that by having a mandated benefit. And I have to admit, I was in the state legislature in Texas for 20 years, and we started out really well because my first term, we actually required insurance companies as mandated benefits to cover children from the time they were born and not wait until they've survived 30 days from birth before they would provide health care. I mean, that was great. But then I saw over the rest of the years, and even maybe now, the laundry list got so big it was almost incomprehensible. Now, I know Alabama has a very small list, but I would compare some states that have such huge mandated benefits. It's really difficult, and I'd like the panel to talk about that, at least in the last 20 seconds I have.
Just a quick comment. I'm a professor of finance and insurance. There is technically not a term called underinsurance in theory in insurance law. It's a term that's been popularized by Karen Davis at the Commonwealth Fund to basically talk about the cost hardships associated with just living, and insurance is part of just living in a Western industrialized society. The point is that this law, this policy, will reduce the premium cost on average for all Americans, and that will enable them to buy insurance easier and faster.
You're talking about the Affordable Care Act.
No, I'm talking about letting people buy insurance across state lines.
Well, that's what the Affordable
And anything the Affordable Care Act is going to do is hypothetical and 3 years in the future, other than the provisions passed already that have provided some protections that are there. Now, to be very clear, I applaud some of the things that are in the exchanges. In my idea, the exchange is a bipartisan idea that actually has a lot of potential and is consistent with the interstate components of
You would surprise me because typically everything in the law was bad, although there were a lot of things in there that we worked on very bipartisan. You're right.
Yeah, well, I'm speaking from the value of tenure. So what I'm trying to say is that this thing that we're discussing, interstate commerce of sales of health insurance, could reduce, and actually from our research shows would, reduce the number of people who cannot buy coverage because the price points are too high from the mandates. And what I want to know is how can the human physiology be so different across states that the mandates have such wide swings? Or is it the true difference simply a difference in lobbying skill across the states in conjunction with insurance commissioners?
Chair thanks the gentleman and yields to the gentleman from New York, Mr. Engel, for 5 minutes for questions.
Okay. Thank you very much, Mr. Chairman. I appreciate it. I'd like to start by saying I'm very concerned that we're holding this hearing today to discuss H.R. 371, legislation that would facilitate the purchase of insurance coverage across state lines. And my concern is the fact that H.R. 371 preempts state consumer protections that are critical to the quality of care and health of the patient. And in addition, This legislation repeals all insurance reforms and patient protections that were included in the Affordable Care Act. I think it's throwing the baby out with the bathwater. I find it aggravating, disappointing, and frustrating that this committee has continuously done nothing but take up legislation that would repeal the Affordable Care Act, punish patients, and put the insurance companies back in control of our health system. I'd like to direct my question to Mr. Larsen. Mr. Larsen, many states have spent years developing standards for insurance plans that they believe not only provide adequate minimum coverage for beneficiaries, but also make sure that providers will be adequately reimbursed for services rendered. If we allow the purchase of insurance policies across state lines, why wouldn't employers look to purchase insurance on the basis of the least cost to them and not on the basis of whether it will adequately provide coverage or payments to providers? I would call it a race to the bottom. Would you?
I think that's exactly right. You're going to see companies, both the insurers and then the companies, looking for the market that has the thinnest and therefore cheapest coverage. And of course, everyone wants inexpensive coverage until they get sick, and then they want comprehensive coverage. And that's why we've got to get a comprehensive benefit package that's available to everyone that's still affordable. But when you go down this route, you end up segregating the market, and the young people get peeled off, and the healthy people get peeled off. And what you have left in the market is the sicker people who get sicker and more expensive, and you're not solving the problem. The only savings you're getting is from peeling off the healthies.
And that's why we have the individual mandate in the Affordable Health Care Act, because if everybody is insured, then everybody has the good coverage. And you don't cherry pick or, as you say, have a situation where everybody wants to pay a minimum and then wants maximum coverage when they do get sick. You know, when you're 26 or 27, my kids are around that age, you think you're never getting sick. And then suddenly there's an accident or there's whatever, and then you find out that you're sick. And if you're uninsured, where do you go? You go, right to the emergency room, which is the most expensive health care for everybody, and we're all paying for it. Now, a number of states, including my home state of New York, have developed programs that assure that if a given insurer in their state were to go under, that the state would step in and pay the bills, assuring that the affected customers would have access to care and providers are paid. So let me ask you this. As a former insurance commissioner, can you tell me, if we allow interstate purchase of insurance, how would individual states protect their citizens and providers from the insolvency of an insurer?
Yeah, and that with all the talk about healthcare reform, that's one of the critical functions of what states do, is make sure that the companies are there when the claims need to be paid. So solvency regulation is critical, and if you lose your ability to ensure the solvency of companies that are selling policies to people in your state, that's a huge loss.
Thank you. I couldn't agree. Dr. Parente, I saw you nodding your head, so I was wondering if you had any comment.
No, I agree. I mean, the purpose of what we're talking about in these laws doesn't get rid of insurance commissioners' functions at all. It just sort of lets the insurance commissioners basically be accountable to the lobbyists for the stuff comes in for the individual mandates, and say, do you realize by putting that mandate into place, you have now priced out somebody that otherwise really needs this care from being able to afford it? And basically makes that more of a dynamic economy about understanding the pros and cons of having that lobbying function. It's great to have these protections, but they don't come without cost, because at the end of the day, an actuary will look at anything that you add and put, this will now add cost to it. It's already happened with ACA, even though people didn't think that would happen when it was first developed.
Okay, thank you. Mr. Chairman, I yield back. Thank you.
Chair, thanks to the gentleman. That concludes our questioning. This was an excellent panel. I want to thank all the witnesses and members for their participation. I remind members that they have 10 business days to submit questions for the record, and I ask that the witnesses all agree to respond promptly to those questions. This subcommittee is now adjourned.